We're here at ACC 15 to talk about the working wounded, health hazards from the interventional laboratory. And it is a paper that is in JACC, the March 3rd, 2015 issue, and it's Occupational Health Hazards of Working in the Interventional Laboratory, a multi-site case control study of physicians and allied staff. So to talk about this, I'm with co-author Mandeep Singh, who is an MD and a professor of medicine at the Mayo Clinic in Rochester. You know, I recall we first reported on this from the ESC meeting a few years ago, where they were talking about this was really beginning to be a problem, and a recognized problem at that. It's an important topic that affects not only the interventionalists and the people working in the lab, but the health team that is around the patient. Give me some background on what drove you towards an interest in this field.
Yeah, so my main driver for doing this study was having been an interventional cardiologist for almost a quarter of a century now, that it was just an observation that most of the faculty who worked at Mayo Clinic suffered from some orthopedic issues. But that was only a subjective assessment, so we keep talking about, you know, why this interventional cardiologist is away today, or he had some back pain or spine pain or whatever. And so that led us to look into literature, and the literature that we found was old, was at least a decade, if not older. And then we also found that it was just an observational case series, and there was no control to compare the results with. And the last thing we found was that all the studies that were done a long time ago just included physicians. And so we wanted to do a contemporary study that compared not only cases which were exposed to radiation and lead apron, but also had technologists and nurses involved who are equally part of the whole interventional team, but then also have controls that were not exposed to radiation and wearing a lead apron to then compare apples to apples.
Now, in this particular case, this is a study of 6 Mayo facilities. So how many people, how many hours, how did you measure all of this?
Yeah, so we have 3 Mayo clinics, Rochester, Florida, and Scottsdale, and then we involve 3 Mayo Health System sites, which have cath lab and radiology as well. And we then combined these 6 clinics and sites, and then also included personnel not only from cardiology but from radiology as well. And that gave us a nice case and control. So cases were personnel, including physician, technologists, and nurses who were working in the cath lab environment, or radiologists who were wearing lead apron for radiation protection, but then gave us the controls, like, for example, people in the echocardiography department or in the nuclear lab, right, which did not wear these. So this was an ideal setup for us. And then we had these individuals who had varying degree of exposure to radiation and lead apron. That actually solved most of our problem that we wanted to solve. We had about 2,600 employees who we sent a survey to, which was made by our service center at Mayo Clinic. And the response rate was about 57%, so about 1,600 employees responded. What we found was, even after adjustment to all the variables that can lead on to musculoskeletal issue, there was a 67% increase in reported orthopedic problems in personnel who were exposed to lead apron and radiation.
And for whatever reason, it seemed like some of the other team members reported more problems than the physician.
Exactly. So it was very interesting because this subgroup of technology and nurses have never been studied. So despite being younger and not being in the cath lab for a longer period of time, we found that almost 60% of technologists and nurses reported musculoskeletal problems, as against 44% of physicians, and much less in fellows who are just starting to get their training on board. And we were fascinated and intrigued at the same time. Why exactly? So we just put forward something that we think make sense and relevance to it. So one thing we thought was that technologists and nursing staff who come on board with cath lab or are exposed to radiation lead apron are not able to move out of the cath lab area. So they are working day in and day out. As against physicians, for example, I work in the cath lab 50% of the time. The rest 50% I work in the clinic, I work in my research, so I get some time off from the cath lab. And technologists and nurses don't. Second thing we found was, if you have a 400-pound patient who is to then need to be transferred from a stretcher to the cath lab table, we don't do that. I think the technologists and nursing staff do that. And so not only it was unrelenting for them, but the kind of work that they do was a little unique to them, that they started reporting these orthopedics issues much sooner than the physicians and the fellows. The other thing we have started noticing is that the type of work that they do, for example, the echocardiographers work with the ultrasound machine and probes, so they have a different kind of musculoskeletal problem than the rest of us.
Well, there are varying degrees of intense activity on this area. Almost all catheterization labs now deal with health hazards, and this is all kind of become a top concern for them. So we've got a problem with the working wounded. What can we do? Where do we go from here to help solve this? Is there a solution?
There definitely is a solution. I think as work warriors, I wouldn't say it's work wounded, but we are work warriors. You know, we've been working for a long time in the cath lab. But as you know, we are so committed in the welfare and upkeep of our patients, we sometimes forget that our own health is at risk. And this study actually surfaces that problem. And what we have started to do is the proposal we are putting forward to our administration is that the technicians and the technologists and nursing staff also need some time off. So maybe a day a week, they need to just go and do some non-cath lab work, similar to physicians. So that's one thing. Second thing is maybe the ergonomics of the cath lab need to change. You know, we need to, not all of us put, for example, soft sole shoes, which is a problem. The design of the lead apron, even though it has changed, they were like, I think, about 20 pounds heavier 15 years ago than they are now. They are thinner, they are better. Now we have a waist and a jacket rather than just one big lead apron. Now realize we wear the lead apron like 8-10 hours a day. As the procedures become more complex, we tend to wear them longer. So change in the whole design and the ergonomics of the lab is another thing that we have to look forward to. The third thing is that proactively we have to then start thinking about sending us, including ourselves, to PMNR, the physical medicine rehabilitation, to just start thinking about some kind of exercise and rehabilitation as we continue to work to minimize and mitigate these problems. And the fourth thing is surveillance, which we have to just think about doing, that every few years we have to then start looking at the data. That because one thing we could not substantiate and confirm was the cancer issue. So we think that cancer still is a problem we could not answer from our study. And for that we need to do periodic surveillance every 4 or 5 years and do the same survey and analysis in our employees again.
Well, if you work at an interventional laboratory or you have friends or colleagues who are part of the HEART team, please check the March 3rd, 2015 issue of JACC and this paper by Dr. Singh. For Cardiol Source World News, I'm Executive Editor Rick McGuire.